All right, good morning. We should get we should get going. Somebody can get a one of the lights back there. Thank you. Hi, Marty. Well, now Marty's here, I can talk about geriatric population. What? If that way, Marty will remind me what I don't remember. No. We're going to talk about geriatric emergencies, trying a slightly new format too. That we've got case reviews embedded in the lecture now, and I think pretty much appropriately where they belong. So, geriatrics now. For argument's sake, the elderly or geriatric population is tagged at 65, although a lot of the trauma surgeons and trauma literature is using 55 as the break for an older population. What? But of course, we're going to refuse that, and I like to think that 75 is not too old too. So, the elderly population over 65, for argument's sake, is one of the fastest growing segments of our population, mainly because a lot of our population isn't reproducing that rapidly anymore. And there's been no major wars, no major other catastrophes. We've managed to avoid the pandemics that have taken down populations in the past. And during pandemics, usually the elderly and the very young are more at risk than persons your age. However, that wasn't entirely true for the avian flu, which basically is a little bit more aggressive for middle-aged persons because of their actually excellent immune status. Healthcare and living standards improved significantly since World War II. Although over the last 2 years now, there's been a slight decrease in the average life expectancy for both males and females in the United States. Partly because, on one hand, women have caught up with men now in death in the percent of deaths from lung cancer due to smoking. Men have declined in that. Women have increased. It's just a catch-up phenomena. And also, we think that there may be, because of the growing obesity problem, that's also having a negative effect on the average or expected life expectancy. Yeah. According to the Census Bureau, between now and 2050, there will be 80 million of us over 65 in the United States. It's not to mention how many are going to be in China and India and a few other places. During the time period 2010 to 2030, so 20-year period, we're right in the middle almost now, the number of elderly will grow by 2.8% per year in the United States. This is where we are. The blues are where there's 14%, blue-purple is where there's 14% or greater over age 65. Heavily concentrated in the mid-central states and in Pennsylvania, West Virginia, and look at Florida, where they should have made it, I think, blue, more blue for the hair color. But then Oregon, almost that high a population. And Oregon, Arizona, where old people like to go to retire, even though in Portland they said that young people are coming there to retire now. Montana, curiously, Kansas and Oklahoma. The rest of the states are much more leaning toward the younger population. Now, what happens as you get older? A lot of things. Multiple system failure, you just become less efficient with age. Decreased circulation, gastric absorption decreases, absorption and distribution from the intestine is slowed, decrease in body fluids, comorbid things, you get other diseases. There's everything from cardiovascular disease to chronic GI problems to cancers, all comorbid things. Patients often accept, one of the problems with the elderly is patients often accept their medical problems as just being part of aging. So they either don't take care of it or they try to downgrade the fact that they are not able to do the things they used to do. Changes in aging lead to different presentations. And some of the things that happen are just, we just sort of take for granted. There's a lot of visual issues that lead to injuries. Cataracts, glaucoma affect the person's ability to see and to interpret what they're seeing. So it increase in problems with automobile accidents, even walking, hearing decreases. It's a big problem with the elderly. I used to give my dad a great deal of trouble because he said he had no hearing problems at all, but he couldn't hear anything. You go to a movie with him and he'd be asking you right in the middle, what'd they say, and now I live with somebody who also does that. It's a big problem. Then there's tinnitus. Tinnitus is ringing in your ears. It causes hearing problems, and then Meniere's disease, which is recurring episodes of vertigo, extreme vertigo, associated with tinnitus. It might be due to viral, it might be due to a metabolic issue, very common in elderly, but causes causes falls, causes inability to function, because you have extreme vertigo. It's also associated with nausea, and people throw up, and they get dehydrated, and they have more problems. Speech changes, partly because you don't hear as well, but it all affects your ability to communicate and to even communicate with medical personnel to tell you what's going on. Age obviously may diminish your mental status. Senility, just being old and not as functional, and organic brain syndrome or dementia may manifest similarly. Don't assume that somebody who's confused or disoriented is, quote, just senile. It may be an organic brain syndrome. And organic brain syndromes, altered mental status, can be caused by rhythm changes, cardiac rhythm changes, or a myocardial infarction, can be pure dementia, can be infection, and we'll go through this today. We see so much sepsis out there right now that we see much more sepsis. Just remember, you see more sepsis than you see myocardial infarction, by far. Medication related, we're going to get to this in a minute. Your problems with medication, too much medication, too little medication, interactions of other medications, the fact that people are often taking more than 6 medications at the same time. Decreased blood volume, relative hypovolemia can affect your mental status, particularly as you're older. Respiratory disorders, COPD, congestive heart failure. Hypothermia is an issue with elderly people. Hyperthermia, particularly recently, this kind of weather. Decreased, hypoglycemia, hyperglycemia, medical or traumatic brain injury. All sorts of organic causes for confusion and mental status change. It's worse with the elderly then. Physiologic changes, decreased circulation, partly due to atherosclerosis, partly due to changes in your blood volume and fluid level. Gastric absorption decreases, so you're not going to absorb nutrients and fluids. Absorption and then therefore distribution is slowed. Your medications may not come in. If oral medications may not, they may show up in the circulation later than expected. And then I mentioned already decreased body fluids, just you're relatively dehydrated. When you get relatively dehydrated, if you have drugs on board, if you're taking any number of medications, that drug concentration is going to be increased just by the fact that it's not diluted. And because we have less protein as we get older as well, less albumin mostly, you get more free drug. Most drugs are protein bound. You get more free drug, so you can get enhanced effect of the drugs. What are the contributing factors to toxicology of prescribed pharmaceuticals in the elderly? First of all, they take a lot of them. It's not uncommon, as you know, when you go through the drug list. And when I go through the drug list that you put in the MIRs, for the elderly population, we often are in the neighborhood of 8 to 12. The average for the 75-year-old age group is somewhere around 14 different drugs. So obviously physicians are prescribing them. There are more adverse effects. We'll get into some of the adverse effects in a minute, but some of these drugs they're either additive to one drug, or they have the reverse effect, or they increase the effect of a drug by causing more absorption or having it go through a sort of a double cycle through the liver in increasing the drug effects. 20 to 25% of hospitalizations are considered to be drug-related due to adverse effects of multi-drugs and also over effect of drugs. Obviously, opioids are a big one. There's decreased compliance, which means that the patient either doesn't take the drug like they're supposed to, or takes them erratically because of how they're thinking. Why do they not take the drugs that they're supposed to? Confused about how much they should take. You know, we've come up with all those where you have the multi-day packs, so you can, you know, put all your drugs to take in one day in one compartment, and then the next day in the other compartment. And people do that, but a lot of times they don't do that, so they take an overdose because they're confused about how much or they don't remember that they took a drug today, so they take another drug. They self-medicate, particularly with over-the-counter drugs, minerals, etc., or take it from a neighbor's drug. How many times you go and find someone who's, you know, they were having some dizziness, so their next door neighbor decided to give them some nitroglycerin or something because it was, you know, obviously they were having a heart attack. Doctor shopping. They find a physician who obliges with drugs, particularly that, you know, would be negative with opioids. Compliance with drugs may be because they're too costly. It is expensive when you look through although Medicare covers a large percentage of drugs, the way that it's set up is that you are responsible for roughly the first $600 or $800. Then there's the golden period from $800 to $3,600 that is, at least you get a supplemental payment and a reduction of the cost of the drug, and then over $3,600 it's back to your cost. Now when you get into really expensive drugs, a lot of the cardiac medications are $100 a month. If you're taking 4 of them, that's $400 a month. You burn off that first $800 pretty quickly, but then you burn off the $3,600 pretty quickly too. So people don't take medications if they can't afford them. They skip doses, they forget. And even worse, they can't read the label because they didn't tell them that I can't read anymore because of my cataracts. So they misinterpret they remember what they used to take, and so they take it. They can't open the bottle. Child-proof bottles are deadly for old people because they can't open them. Children can open them because they bite them. Old people don't have teeth, they don't bite and turn. So, poor compliance. Here's some of the factors for poor compliance. When you go to a place, if the person's living alone, they're not going to comply with drugs. They have no family doctor. It's the relationship with the doctor and somebody who understands that the patient has problems, you know, and it will not, and they may not overprescribe them. They're demented, forgetful, depressed. People who are depressed don't take their medications like they're supposed to. Alcohol abuse, we never see that. They want a quick fix. In other words, they want an answer that works. They want a pill that will make them well now, will make them 35 again now, and it doesn't exist. It takes the time. No insurance, fixed income, all these things contribute to poor compliance. Okay, first case review. Patient states just took Cipro 20 minutes ago. Started to feel itchy, hands and feet started to swell. She took 15 mils of children's Benadryl. It's not helping. Why does an adult have children's Benadryl around? I don't know. She obviously doesn't have children. She's taking Cipro for UTI. She says she's never had this medication before. She had an anaphylactic reaction in the past to penicillin and codeine. She used to carry an EpiPen. Starts to feel very itchy, crawling up her arms. Her throat feels like it's starting to close up, having trouble swallowing. Denies headache, chest pain, nausea, vomiting, shortness, breath, dizziness. Sitting in a chair, alert and oriented, anxious. Skin is normal color. Patient's hands and feet are swollen. There's a raspy sound and auscultation of the throat. Transported without incident. Blood pressure with 210/90, somewhat on the high end. Pulse 100, pulse ox 96, pulse ox 96. Blood pressure rechecked 140. Got some diphenhydramine. IV, methylprednisolone, IV, epinephrine 1 to 10,000 as a drip. Now, anybody see anything in this one of interest? 1 to 10,000 epi, you know, it's kind of out of order. And we checked on it, and yes, it's indeed in, you know, if you're thinking anaphylaxis, the first thing they need is epinephrine. That's the order. She did fine, by the way. She went to Southwest, and she was breathing well at that time. Her raspy noises, sort of stridorous noises, had disappeared. Her blood pressure was stable. She did fine on the epi drip. The Benadryl kind of mellowed her out. It should be given, you know, after the epi if you have true anaphylaxis. And then, you know, the question is, why did she have an allergic reaction? She'd never taken the Cipro before because, at least she knew, there's a lot of different medications that are similar enough in structure that would probably give her, you know, could cross-react. Theoretically, you can't have an anaphylactic reaction without having the medication before. She may have had it and not known it. That's the best bet. In here, because allergic reactions occur in this age group, and the epi drip is safe. Okay. Here are some of the adverse effects and interactions that we have with medications. Now, benzodiazepines, lots of people get benzos. Not as much Xanax anymore, because Xanax has a bad name with the DEA and with the pharmaceuticals. So because it's very habit forming, very addictive. Valium is Ativan, Librium, Transine, Dalmane are all out there for various persons who say they're anxious. Adverse effects, just normal adverse effects of taking these drugs, and particularly if you have other things on board too, are ataxia, dizziness, confusion, and then they interact with digitalis. You can get digitalis toxicity if you're taking anxiolytics. It will affect people who have Parkinson's disease if they're the levodopa it'll decrease the effect of levodopa and make the Parkinsonian effect worse. And of course, it potentiates alcohol, and alcohol potentiates anxiolytics, so that you get more ataxia and dizziness. The end point of overdose of, remember, of alcohol and anxiolytics, benzodiazepine, is ataxia and nystagmus. You find nystagmus in persons who have an overdose of alcohol and that. Antidepressants are on the move again. We had a decrease in tricyclics, but now they use tricyclics a lot for elderly persons who have chronic pain, and it helps you to sleep, but it also gives you lots of other problems. And remember, the real problem with tricyclic is that the therapeutic and the overdose, the toxic amount is very close. Typical of the tricyclic, Elavil, Cinequan, Triavil. Adverse effects: urinary retention, constipation, which is a real issue with elderly people, dizziness, drowsiness, trauma, blurred vision. Overdoses of tricyclics lead to what? Besides death. Yeah, widening QRS, tachycardia. It will, you know, it predisposes to, because it affects the phase 3 repolarization. It predisposes to torsades. So it's a QT prolonging drug. High doses of Benadryl are also QT prolonging drugs. So we're going to make a change. In addition, we're adding to your orders. If you're treating someone who, what do you treat someone who has an overdose of tricyclic? Bicarbonate. You'll do the same with Benadryl overdose. Why would somebody have a Benadryl overdose? They want to get high. They want the anticholinergic effect of high-dose Benadryl. Patients, for a number of reasons, may be taking anti-nausea drugs, adverse effects, blurred vision, drowsiness, muscle cramps, rare seizures. Tigan is a very common drug nowadays. Now, medications for reflux, very common. Tagamet. Adverse effects of Tagamet: headache, drowsiness, confusion, disorientation, psychosis, hallucinations, and they interact with so many. I was going to bring that up, but they interact with so many medications, and it can make the effect of the medication worse or the effect less. I couldn't put a slide together that had all those effects on it, because the adverse and significant effects, at least in my reference stuff, list about 300 different drugs, common drugs. Erythromycin, you get toxic doses of erythromycin if you're taking Tagamet. Warfarin, you can get suboptimum levels of Coumadin if you're taking Tagamet along with it. And people don't know that. They don't. Opioids, it makes the opioids more potent. Yeah. The pharmacists are getting pretty good about it now. But the problem is, we found with a lot of the guys, is they go to, now, if you're on Medicare, it's pretty good because it's nice because you have to sign up for a pharmacy. But people go to different pharmacies to get different drugs. And you may not go to if you're getting an opioid, or if you want an opioid, they don't know necessarily. Tagamet's over the counter now. So you don't have to, pharmacist doesn't necessarily know it, and depending on how busy they are, they may not sit there and do counseling. And what they do is, the simple way now is, if you go to the pharmacy, pick up a drug. When I go in to get my drugs, they say, "Have you taken this before?" And all you have to do is say yes, and they say, okay, well, you know about it already. They don't cross-check it. Antidysrhythmic drugs, a lot of them out there. Cortisone, one of the effects of cortisone is that it increases the likelihood of heart failure. Hypotension can increase tachycardia, blurred vision, lack of coordination. Norpace is another common one out there for ventricular dysrhythms. Worsens congestive failure, causes dry mouth, nose, throat, urinary retention, constipation. Isoptin, which is a calcium channel blocker, adverse effects is, and that's given for supraventricular tachycardia, constipation, drowsing, dizziness, lightheadedness. Lanoxin, common, even though less common than it used to be, digoxin. Adverse effects are dysrhythmias. It causes heart block, which can lead to more dysrhythmias. Yellow tint to your vision. Tambacor, which is given for both atrial and ventricular tachycardias and dysrhythms, worsens congestive failure, dyspnea, visual disturbances, etc. The NSAIDs have lots of adverse effects, mostly GI bleed, depression. Indocin can actually aggravate Parkinson's disease, fluid retention. Indocin is an excellent drug, but has a lot of, it's better given to young people who can tolerate it. But people do take a lot of ibuprofen, and ibuprofen has renal problems, and so you can get renal failure from taking long-term NSAIDs, and because it's antiprostaglandin, excuse me, it affects, it can affect the a plaque, coronary plaque, and cause disruption of the coronary plaque. So it can increase your risk for myocardial infarction by disrupting the coronary plaque. Antihypertensives, Aldomet, Reserpine, edema, dizziness, weakness, nasal congestion, depression. Inderol, commonly given for antihypertensive, as an antihypertensive drug. Inderol just slows you down, makes you fatigued, sleepiness. That's why most young people won't take it. Oral hypoglycemics, obviously severe hypoglycemia and lactic acidosis. Remember the oral hypoglycemics, if the patient has a hypoglycemic episode while on an oral hypoglycemic, treat it normally, but then that patient, I want to see that patient in the ER for evaluation as to why they got hypoglycemic. I can tell you from experience that back pain, muscle aches, etc., are very common in the older person and the younger person. And whereas muscle relaxants, Flexeril, Robaxin, stuff are commonly prescribed for younger people and with good effect, as you get older, they have severe CNS depression, dizziness, blurred vision, headache, drowsiness. It's probably not worth it. Norflex, which is non-narcotic, anticholinergic, muscle relaxant, causes fainting, tachycardia, palpitation, urinary retention, lightheadedness, constipation, all those things that we love as we get older. Demerol, Tolwyn, Darvon, Vicodin, you can throw morphine, etc. on there. Adverse effects, respiratory depression and arrest, bradycardia, hypotension, etc. And actually urinary retention is common with Tolwyn and with other narcotics. Now, people love to take over-the-counter drugs, particularly herbal supplements, vitamin supplements, etc., none of which have been checked out by the FDA, none of which have scientific studies, or very few have any scientific studies. It's very popular because you can do it yourself. You don't have to go to your doctor. You don't have to put up with all that stuff. We spend $40 billion at least annually on herbal supplements. And they take them for all sorts of different reasons. St. John's wort is taken for an antidepressant. But the adverse effects of St. John's wort is GI upsets. If you happen to have, if you're taking antiretroviral drugs, i.e. if you have AIDS, it may interfere with the uptake of these and interfere with the drug itself, so you're not helping yourself at all. Ginkgo biloba is very common. People take it for after they've had a stroke, for allegedly to improve memory, improve or to treat impotence, maybe just, you know, maybe just forgetting that you know, are impotent. I don't know. Macular degeneration, tinnitus, they take it for everything that's brain related. No one knows if it works. It's not, there's no studies on it, but it can cause increased bleeding, nausea, vomiting, diarrhea, and because it increases the, so if you're on warfarin, Coumadin, or any of the anticoagulants, can increase the effect of that, which means you bleed a lot more significantly. People take garlic pills to lower cholesterol, lower blood pressure, as a non-Coumadin anticoagulant. Even take it for antibiotics and antiviral. Adverse effects are obvious: garlic, odor, heartburn, gas, can enhance bleeding disorders or the effects of anticoagulants like Coumadin. Ginger is very popular. You know, if you ever do any boating, that's ginger in any sort of form. Ginger tea, ginger pop, ginger pills are thought to really help with seasickness. I don't know. I noticed that didn't seem to improve my wife's seasickness at all. So, but you can get it over the counter. You don't have to get the other stuff. Adverse effects of too much ginger, believe it or not: CNS depression, dysrhythmias, and it may interact with your anticoagulants, with Coumadin. Ginseng, okay. People take it for mostly energy and for improving their sex life. Makes you nervous, gives you a headache. Well, how does that improve your sex life? And hypertension and hypoglycemia can occur with ginseng. Marijuana, we know what we get with marijuana, besides the munchies. Melatonin, this is a sleeper. The people take this to improve their sleeping. Adverse effects, though, are grogginess, drowsiness, sleepwalking, disorientation, makes asthma, if you get asthma at night, makes it worse, may affect other tranquilizers. If you're taking magnesium supplements, you'll get increased cramps. Valerian, which almost looks like marijuana looking at it, Causes, and take it for sedation, improving sleep, restlessness, nervousness, but adverse effects of valerian, palpitations, headache, GI upset, blurred vision, etc. Yohimbe, which is the over-the-counter version of Viagra, causes dizziness, insomnia, anxiety, hypertension, tachycardia, hallucination, weakness, paralysis, etc. Believe it or not, grapefruit juice gets you. Grapefruit juice inhibits certain isoenzymes that are necessary for drug metabolism, increasing the risk of toxicity for the drug, increasing the risk for drug interactions, and decreasing the potency of some drugs. So, drugs that are affected by grapefruit: Valium, Verapamil, Versed, Xanax, Viagra. So, shouldn't have a quick pick-me-up before you have a pickup. Cardizem, Cortisone, erythromycin, nifedipine, Lipitor. There's a whole bunch of things, and they don't, the pharmacist can't go through all those things and ask you if you're taking excessive amounts of grapefruit juice. Now, does that mean you can't drink a glass of grapefruit juice every day? Well, you probably shouldn't if you're on any of those drugs. Can you eat a grapefruit? Probably, because there's not that much grapefruit juice in a grapefruit. Okay, here's a few more common problems of older persons. Pneumonia. They develop pneumonia more frequently. Why? Well, at the extremes of age, so between roughly 6 months and 18 months, and then after 65, we have relative decrease in your immune status. Now, for little kids, and we're talking mostly pneumococcal pneumonia, strep pneumonia. For little kids, that's because they had maternal antibodies against pneumonia and a whole bunch of other things, but they start disappearing at about 3 to 6 months of age. So at 6 months of age, they haven't had it. So, and beyond 60, 65, we just have a decreased immune sensitivity, and we start to lose our antibody against particularly pneumococcus. This is why at age 60 or so, they start recommending that we get a Pneumovax, a Pneumovax vaccination every so often. Used to be every 5 years. I think it's still about every 5 years. They may not have typical symptoms. The problem as we get then significantly older with our pneumonia, we don't have the ability to, because of the immune system, we don't have the ability to mount the same response that we did to pneumonia. So typical symptoms may be absent, such as fever. Patients may have they may just have a change in their mentation, particularly if the patient is in sepsis. So, I mean, how many times do we go nursing home and they said, well, they're not their self today. They're not eating, they're not interacting like they normally do. Or they say, we don't, it might have happened 2 days ago. And that person is septic, pneumococcal septic. They may present with chest pain, simple lethargy, shortness of breath, decreased O2 saturation. Sepsis that inflammatory response is blunted because they don't have they can't mount a full aggressive inflammatory response, which, you know, which is protective most of the time. Most common source of infection for sepsis is respiratory, followed by GU system. Always be suspicious of sepsis in any elderly patient who has the potential for an infectious process. So if they have respiratory symptoms, if they have urinary tract symptoms, or if they have a catheter, particularly if they have a strong odor of urine about them, and they've got a change in their mental status or change in their appearance, we will bet on sepsis. Considerations for septic shock per your orders: known or suspected infection with 2 or more of the following: temperature greater than 38 centigrade, which is 100.4 Fahrenheit, or because they can't mount a decent inflammatory response, they are hypothermic. Temperature less than 36 centigrade, which is 96.8. So it's basically 2 degrees above, 2 degrees below your usual temperature, normal temperature. Respiratory rate greater than 20 breaths per minute, heart rate greater than 100 beats per minute, or an EtCO2, nasal, of less than 25 millimeters. Now this just indicates basically hyperventilation, right? Which is a good surrogate. It's turning out to be a very, very good surrogate for lactic acidosis, because they're not ketoacidotic, they're lactic acid. Shock, sepsis, increases the lactic acid, and you have the same normal response to acidosis as you do with ketoacidosis, as you hyperventilate. And they may not obviously be breathing too much. However, the respiratory rate's greater than 20, which is, you know, certainly 6 to 8 points more than you normally breathe per minute. A lactate meter, some places are using a lactate meter, which is like a glucometer to determine actual lactate level, but that requires, none of the machines, it turns out to be approved for field use, just because the FDA doesn't do that. It's not to worry about it. Strictly speaking, your glucometers aren't approved for EMT use either. They're approved for home use. That could be a whole other discussion as to what the FDA thinks is real and not real. But these are it correlates very well, and we've already got, you've already got a great CO2 detector, so this is good. So 2 of these and a systolic blood pressure less 90 or less, or altered mental status, that becomes a septic shock alert. If the patient is normotensive or not altered, and they have 2 of those findings, then take them in non-emergent, code 1, notify hospital personnel that this is possible sepsis. That increases the, what kind of a response do you get if you get a septic shock alert? Code 3, so the doc will see them immediately. Yeah, yeah. But So with a septic, if you tell the nurse that the patient is possible sepsis, they'll start the process to do the hospital workup for sepsis. Well, 88-year-old, chest pain, generalized weakness. Patients walking from the bedroom, on arrival, patients walking from bathroom to bedroom to lay down. Symptoms began, quote, 2 hours ago, doesn't like going to the hospital, so he didn't want her to call. States he sat up in bed most of the night, which is not normal for him. Past history, dementia, pacemaker, COPD, IDDM, and bradycardia. He's denying any symptoms at the moment. Denies chest pain, complains of weakness only, which I guess is a symptom. 88-year-old, 80 kilogram, cool, pale, dry skin, pupils equal round, airway open and patent, breathing mildly labored with rales, bilateral bases, able to speak in complete sentence with an occasional cough. 12 lead shows right bundle branch block with ST elevation in 1 and AVL. Remainder of the exam's unremarkable. Blood pressure's good. Heart rate's 125. SpO2 91. 12 lead shows elevation in 1 and AVL. Began transport. Blood pressure felt at 96/62. Heart rate 110. SpO2 97. Blood glucose is elevated, but okay. Here's the 12 lead. And indeed, I do see some ST elevation in 1, at least what appears to be ST elevation in 1 and AVL. I don't really see any place else. I don't see any significant depression. I do see what appears to be a right bundle branch block pattern. So theoretically, you can read ST elevation in a right bundle branch. Patient did not turn out to be a STEMI after review of the hospital 12 lead, and indeed the 12 lead in the hospital, I'm not sure whether it has to do with position. I'm not sure, shouldn't have made any difference with, with the limb leads, but there was absolutely no ST elevation in 1 and AVL. It was perfectly okay. So I don't know what that's all about. I can understand looking at that from the paramedic standpoint. I can see that, yes, it is ST elevation. I don't know why. Now, from my experience, it's very uncommon to see just 1 and AVL, although that's called a lateral. It's still uncommon to see just those two. Usually you see something else with it, either V6, V5, something like that. I have no problem with it calling us a STEMI. It worked out fine. Anyway, patient had a fever. Patient, by the time they got to the ED, had low blood pressure, was admitted for sepsis, probably from the lung, low-grade pneumonia. Also had a history of congestive heart failure. I mean, it's really set up for it. Comorbid factor. The old guy has, he's had coronary disease before. He's got a right bundle branch block. He's had things done to him in the past. He has an ejection fraction of only 30% or so. So he's set up for congestive failure, and doesn't need much to tip it over. Little sepsis, there it goes. I think that's about 50, isn't it? Okay. Chronic obstructive pulmonary disease. And, if you've been a smoker, if you've had exposures, if you've had bad luck to get idiopathic pulmonary fibrosis, you end up with chronic obstructive pulmonary disease, characterized by chronic airflow obstruction. Sometimes it's reversible. Reversible is if it's a reactive airway, asthma or other reactive airway syndromes. Elderly patients commonly have a bit of both. They have a reactive component, allergic component, and they have chronic obstructive irreversible changes. COPD is progressive and debilitating. Pulmonary embolism, blood clots are the most frequent cause. Usually clots come out of the deep veins of the leg in the elderly, and generally speaking, if they have some degree of immobility. Either they're bedridden or they're just not moving around much. Treatment is oxygen IV, anticoagulants, positioning, etc. And we take severe ones now to the cath lab to actually extract the clot. Pulmonary edema, alluded to this already briefly. Acute pulmonary edema can develop rapidly. Rapid onset pulmonary edema, flash pulmonary edema, is usually caused by a myocardial infarction. So always look for that. You have sudden, unexplained, now, gradual, overnight progression of shortness of breath is not sudden. I'm talking flash pulmonary edema. They were okay 5 minutes ago, and now they're in fulminant pulmonary edema. Think of MI. Can also occur if you rupture a chordate tendon or something like that, but that's a little bit more uncommon. How you can get, obviously, pulmonary edema occurs when you have pulmonary infection, a pneumonia, which is in the presence of a lowered, chronically lowered ejection fraction, inhaled toxins, narcotic overdose causes pulmonary edema. It's not cardiogenic though, so it won't respond to your usual treatments for, well, what we now have pretty much settled down on treatment for pulmonary edema. We're going to use either CPAP and nitrates. Nitrates won't help too much in the pulmonary edemas that occur from narcotic overdose, but CPAP and or intubate the patient and use a PEEP valve with 5 to 10 pressure. Treat the underlying cause. If it's narcotic overdose, start out with Narcan and then treat pulmonary edema, non-cardiogenic pulmonary edema with the CPAP or PEEP. Myocardial infarction, elderly patient is less likely to present with classic symptoms. So no chest pain, maybe chest heaviness, maybe simply fatigue, unexplained fatigue. Dysrhythms, just like with the young person, dysrhythms are the leading cause of sudden cardiac death in those initial hours after an MI. And so early detection during the period of the MI. And we are now taking, I think the oldest person I have recently seen go to the cath lab was well into her 90s, getting a stent. 70-year-old male feeling ill and with vomiting. 30 minutes ago became ill, started vomiting. Stacy was sitting at a table and began feeling sick, no chest pain, shortness of breath, headache, blurred vision, recent falls or trauma. Stacy had a heart attack with a stent placed 4 years ago that presented exactly the same way. Says prior to 30 minutes ago, he felt fine, having a normal day, denied eating anything, made him sick. Past history, diabetes, congestive heart failure, myocardial infarction, and a stent. Patient sitting in a chair, alert, oriented, complete sentences between vomiting, breathing at a normal rate, profusely diaphoretic, cool. Able ambulance to gurney approximately 6 meters. During transport, patient begins vomiting again without any other changes in condition. He got some volume. His blood pressure is 140 to 50, over 105, pulse 76, respiration 16. 12 lead shows a left bundle branch block. Got some ondansetron, improved. Pulse ox 98. And here is his 12 lead. First one is because the top one's a little confusing because of the PVCs, but clearly a left bundle branch block. I do not see any evidence of concordance or any of the other Scarbosa criteria, and so this was not called as a MI. And this is exactly what his 12 lead looks like in the hospital. They then ran enzymes. His enzymes were normal. He was admitted for nausea and vomiting with dizziness, and ultimately they thought that no cardiac issue. They thought he was fluid short and probably just mild symptomatic heat exhaustion. Yeah.
Someone with that, he's got a history like that.
Yep.
Looking at me, he's silent in my.
Yep.
That left bundle, but it looked like a low venture or something like that. That's the only reason on that. But
But you can't read it in a left bundle branch block.
But if someone was having chest pain
Mm-hmm.
like that and was non-STEMI, I'd take him in hot.
Mm-hmm.
Yeah,
Yeah, I would still.
I
wouldn't. It wouldn't hurt me. It wouldn't hurt me in any to take him in hot, because you don't have the advantage of having now. With the Pulsera, we'll send this in to, and the ER doc could, if he's been a patient there before, which he was, he could probably pull his old record in a matter of seconds, his old EKG, and compare it and say, okay, it's exactly the way it was. You can still come in hot. He's got chest pain or not chest pain with that. He says, this is exactly what my MI was like before. Just don't call it a STEMI.
Right. But,
Yeah, exactly. Yeah, of course. And so it's a good case because in older persons, they may not have chest pain, and it's confusing. It's hard work to sort it out because nausea causes vagal stimulation, which causes diaphoresis and, bradycardia and hypotension and all sorts of things. So, and the trick is to not do more than, so they treated this one with the ondansetron, which improved him, and then we just have to sort it out. Okay, heart failure. Heart failure occurs when cardiac output can't meet the body's metabolic demand. And your four categories of heart failure are impairment to flow, inadequate cardiac filling, so you have decreased preload, volume overload when there's just too much fluid in general, and then myocardial failure itself. So chronic congestive failure usually is volume overload, and then they add a little bit more volume to their system, and then they develop congestive failure if they're stable on their medication. So that's the classic one who wakes up in the middle of the night, sits up, and is able to breathe after a little bit as gravity takes effect. Aortic dissections may occur in the thoracic aorta or in the abdominal aorta. Thoracic aorta is actually divided into two sections, the ascending aorta and just to the left carotid takeoff, and then the rest of the thoracic aorta, which is a separately managed, nowadays the thoracic aorta and that descending loop, the treatment is mostly by controlling blood pressure and medical treatment. They don't operate it as much. Now, abdominal aorta gets operated, the ascending thoracic aorta gets operated on too, because those are pretty deadly. Tearing chest and or abdominal pain radiating to the back. So it is generally described as a tearing sensation. Hypotension is late. Decreased pulses in cold distal extremities may be present, or a differential in blood pressure between the upper and lower extremities. Management, if they're hypotensive, you support blood pressure. Try to get their pressure to at least into the 90 range for transport, or during transport. If they're hypertensive, we'd try to reduce their pressure slightly. And the way you reduce pressure in the field would be with some nitroglycerin. Good segue to hypertension. Hypertension defined as blood pressure greater than 140/90, although symptomatic. In order to treat that, you need symptoms. Now, an internist will probably treat it with medications if your pressure is 140/90. Hypertension likelihood increases with age simply because of increasing atherosclerosis. You get less stretch of your of arteries, and you have to raise the pressure in order to drive blood forward. Obesity, diabetes contribute to this. Symptomatic and symptoms of hypertension include headache, tinnitus, which I said is common in the elderly anyway, epistaxis, spontaneous nosebleed, nausea, vomiting, sometimes tremors, and we treat it symptomatically. Severe hypertension with symptoms of headache without focal neurologic sign, we would allow you to decrease, to try to treat blood pressure slightly with nitroglycerin. Syncope occurs when blood flow to the brain is temporarily stopped or just simply decreased severely. Common presentation, vasodepressor syncope, vagal stimulation. Orthostatic syncope, particularly patients who are on medications, antihypertensives, other cardiac medications, and narcotics, and benzodiazepines. If they stand up suddenly, they'll get dizzy. A lot of us do that. You know, sometimes if you are in a cramped position, you get up quickly, you get a lightheaded feeling. Well, that's what they get, severe orthostatic syncope. Vasovagal is the vagus nerve gets stimulated for some reason. It can occur from abdominal discomfort. It can occur from severe pain someplace. Inferior myocardial infarction commonly causes severe vagal stimulation. Drops your blood pressure, drops your heart rate. You get syncope. You can have cardiac-induced syncope, dysrhythms, etc. Have to sort out whether this is a seizure, because the patients will, or bystanders will often say, well, they look like they had a seizure. Ask them what they mean by that, and they'll say, well, it's very common with syncope to have a few seconds of basically anoxic twitches. There you get some tonic-clonic, but it's not a prolonged, it doesn't go on long enough to be called a seizure. It's just that the brain is having a little spasm because it ran out of oxygen for a brief period of time. Also, transient ischemic attacks could be confused, can present as a syncopal episode. So, you have a 68-year-old male who passed out. 62-year-old, how old is it? 62 or 68? 68 in one place, 62 in the other. He became young quickly. I think it's 68-year-old male. 150 kilograms, sitting upright in a chair in front of residents, alert, verbally profusely diaphoretic. He had been incontinent of urine. Family on scene report he passed out for approximately 1 minute, no seizure-like activity. Appeared weak, unable to keep his eyes open for any long period of time. Hypotensive, bradycardic, 12 leads showed Brady with hypertrophy. Family reported, I put water on him and slapped him to wake him up. That's my kind of family. Stated he was soaked due to sweating, but not from the water. Like, how much water did they put on him? I don't. Patient denies any chest pain or shortness of breath. Family reported a cardiac history with 6 stents in the past. And here's his 12 lead. So what do you see? Well, he's definitely bradycardic. His rhythm appears to be, well, probably a sinus brady. And what's V1 look like? V1 is pretty close to a left bundle branch block. So I'm not gonna bet on that little bit of ST elevation that appears to be in V1 and V2. And I don't see much of anything anyplace else. Don't see any concordance. It's definitely a left axis deviation, and I suspect the left bundle branch block. So, EMS was unable to perform full neuro assessment due to weakness. Groups are weak and equal. Family stated patients normally very alert, not presenting like this. Given IV fluids, Zofran for nausea, transported code 3 to his medical center due to ALOC and poor appearance. Vitals improved, still remained altered. What was his blood? Well, his blood pressure was there. Blood pressure started out at 92/60, pulse of 44, pulse ox 96. Blood pressure came up ultimately to 116/65, and pulse is 52. Got some ondansetron down here. I don't call this LVH. He doesn't really hit criteria. I get 1, 2, 3.5, 4, 5. I get a maximum of 25. I'm not going to call him hypertrophy. He's the left axis deviation, and I think he's almost on the line of being a left bundle branch block, and I think this is probably chronic. And I think it compared to his old, so. They felt he was just a severe vasovagal syncope. Now, my question, well, would anyone have done anything differently on this guy? He got some fluids. He got some ondansetron for his nausea. Why not a little atropine for his bradycardia? 0.5 of atropine, and he probably would have jumped up and said, I'm not going to the hospital. No, I would have taken him to the hospital anyway, but, I mean, he certainly had a syncope. Now, so this is, you know, if he'd had twitches, if he'd had seizure-like activity, I mean, he became incontinent, which is also probably a indication that he had a kind of vagal stimulation going on. So he became incontinent. I would definitely have treated his, I would have treated his bradycardia as well. A little 0.5 of atropine, probably dry him. He was diaphoretic, incontinent, syncopal, hypotensive, bradycardic. What part of I wouldn't treat this with atropine don't I understand? I would definitely do that. You're not going to race his heart and get him into trouble. He's not having an MI in the first place. Strokes. Signs and symptoms of stroke vary. Altered mental status, coma, paralysis, slurred speech, mood change, seizures. I know we've talked about stroke. We had a recent stroke lectures and recent stroke changes, but this is to refresh that because we are now using BFAST, not just FAST. BFAST, balance. So sudden loss of balance or coordination. Eyes, sudden loss of vision in one or both eyes, or in a visual field. Now that's more difficult to sort out because a patient may not be aware that they are missing a visual, you know, you have to do I don't think we have time always to do a visual field check, which is very simple. You just have them look at your nose and wiggle your fingers on the side and see if they come to any point where they've lost a part of the visual field. That's occipital cortex. So it's the posterior strokes that we're going to pick up with balance and eyes. Also, face. Okay, so the common one that we've had before, the FAST, face, symmetrical during smile, arms, look for arm drift, speech, repeat a simple phrase. That'll also pick up your aphasics. Not just slurred speech, but aphasics, the ones who cannot speak or can't find the words. They can't repeat your words afterwards. And then time lasts normal. That hasn't changed. Then if BFAST is positive, then we do a LAM score, a Los Angeles Motor Score. And we're looking for facial droop and rating that. If there's no facial droop, it's a 0. If it's present, any facial droop, 1. We already looked at that in the face. Arm drift, hands out, eyes closed, thumbs pointing to if an arm drifts away, if it drifts down, that's a 1. If it falls rapidly or they can't raise their arms, that's positive. That's a 2. Grip strength then, normal 0 points, weak grip 1, no grip at all 2. Generally speaking, if they can't hold their arm up, or they're also not going to have grip strength. If you put that total score together, they have a LAM score of 4 or 5. That patient goes to where you can get interventive care, which is Southwest. Now, we transport code 3 emergent if there's less than 8 hours of the following symptoms: aphasia, facial droop, unilateral weakness or paresthesia, inability to understand others or verbalize understanding, loss of vision in one eye or visual field, sudden onset of vertigo, particularly if it's persistent, particularly if there's headache, but any sudden onset vertigo. They went to bed normal and woke up with symptoms. We're assuming that happened within the 8 hours then. Usually it happens right about the time they wake up. It's usually what wakes them up is the stroke. Notify receiving facility of code 3 stroke. Now, patients who meet criteria for transport emergently will go to PCEP Southwest. They have a LAMS 4 or 5 greater, or 4 or 5. Any patient 80 years or greater, because they're likely not to get simple TPA. They're likely, if they're going to need anything, to go to the cath lab. Symptoms more than 3 hours in duration, because it takes about an hour to work somebody up, and so you're over the time period of safely giving TPA if they start out in your care at more than 3 hours, they're going to be over the time period of safe TPA, and they will only be able to get intervention. If you suspect intracranial hemorrhage, they need a neurosurgeon, and the neurosurgeons work at Southwest for operating. Signs of profound paralysis, aphasia, or comatose. Those patients are going to need interventive care. They won't be able to pass or fail your LAMS test because they're comatose. It's impossible to test a comatose patient with any of our tests. They can go to the closest stroke center if their symptoms are 3 hours or less or above criteria are not met. You know, if the LAMS score is like 1. Closest stroke center or patient family choice. Now, dizziness and vertigo. We'll get back to dizziness may indicate the patient's had syncope, pre-syncope, lightheadedness, or true vertigo. Strictly speaking, vertigo is spinning dizziness. The world spins around you or you spin around the world. Often accompanied by sweating, pallor, nausea, and vomiting. Vagal symptoms. It is virtually impossible to distinguish dizziness from pre-syncope or syncope in the pre-hospital setting. It's very difficult to do that in the ER. It's very difficult to sort it out. I mean, the neurologists are good at that, but sometimes I think they're kind of shooting in the dark too. The point is, anybody who has dizziness or vertigo as they're presenting symptoms needs to be evaluated by a full workup and a neurologist. Now, if they have simple vertigo from labyrinthitis, inflammation of their balance mechanism, that's fine. That'll go away. That'll be okay. They could have Meniere's disease and have recurring vertigo, but we cannot make that determination in the pre-hospital setting. So that's where the B fast comes in, the balance. You bring them in to rule out stroke. You tell the patient and the family, we cannot determine that this is or isn't a stroke. If it's a posterior stroke, it's a big deal. Needs to be treated. Delirium, dementia, and Alzheimer's disease. I forget which is which. Dementia is a chronic global cognitive impairment. It's often progressive and irreversible Alzheimer's is the most recognized, but not the most common, it's the most recognized dementia. Delirium is global mental impairment of sudden onset and often self-limited duration and caused by reversible causes. So, dementia is chronic, slowly progressive, irreversible, greatly impairs memory with global cognitive deficits, doesn't require immediate treatment. It's not emergent. It's not going to get better. It may get a little bit better, but it's not going to go away. It's a progressive, slow thing. Delirium is rapid in onset, fluctuating course, may be reversed, especially if treated early, and especially if it's due to an identifiable underlying cause, such as a toxidrome or an infectious process. It greatly impairs attention, not so much memory, may have focal rather than global cognitive deficits. So, can be caused by systemic disease, including diabetes and things like that, drug toxicity, or metabolic changes, hepatic failure, renal failure, other metabolic changes, and does require immediate treatment. So delirium, the presentation varies greatly, can change rapidly. If you're going to treat, you should, if you're making a choice, say, is this dementia or is this delirium, err on the side of delirium, because there are reversible causes and you can treat that. You can't make the Alzheimer patient significantly better. Now, an Alzheimer patient could have an episode of delirium if they became toxic on medications or have an encephalitis or a meningitis or an underlying sepsis with fever. They might become have a delirium, and that needs to be treated. So any sudden change, think delirium, we're going to treat that. Dementia is much more prevalent than delirium. Progressive disorientation, shortened attention span, aphasia, nonsense talking, commonly as hallucinations. We often talk about sundown syndrome, that at nighttime, because there's less visual, auditory stimulation, patients hallucinate and become more agitated during the night. Patient often cannot communicate very adequately, so that affects our ability to treat them. A little caveat here: remain alert to signs of abuse, particularly if the patient's living at home. Alzheimer's disease is a chronic degenerative disorder that attacks the brain and results in impaired memory, particularly new memories, current memory. So short-term memory is lost immediately. They remember way back when. Thinking and behavior. Parkinson's disease. A degenerative disorder, changes in muscle response, including tremors. Classic tremor of Parkinson's is what's called pill rolling. You can imagine somebody having a pill in their hand and rolling it over and over and over. That's the kind of pill rolling tremor. Also gait disturbances and other muscle, they have a rigidity called lead pipe rigidity of their, so if you ask them to flex their arm and you're putting a little pressure against it, it nobody here knows what a lead pipe is anymore, but a lead pipe, if you were to, you can bend a lead pipe and it has this feeling of it gives, but it gives oddly. It's a kind of a smooth stretching of, and that's the same with their muscle. They have this rigidity of flexion. It affects their gait, mostly wide base gait with a kind of a shuffle. It affects the basal ganglia of the brain, which is where this muscle effect occurs. It's treated obviously with dopamine is one of the and dopamine-like congeners, which improve the amount of dopamine in the brain. Muscles become progressively more rigid, slow movement. Sure, it does affect speech to some extent. Many patients will live with Parkinson's disease for 20 or 30 years, slow progression. Some people rapidly decline. I've had a couple of friends who have died of Parkinson's disease because ultimately they developed a severe dementia associated with it, and ultimately they die of basically respiratory complications and difficulty with swallowing, difficulty with keeping secretions out of their lung. They get pneumonia and ultimately die. You're not going to treat and cure Parkinson's disease. You're going to be called for the symptoms, whether in sepsis, they're having problems with respiratory failure, whatever. Diabetes, type 2 diabetics, diabetes is more prevalent in elderly patients. They may, if they're undiagnosed, which is uncommon nowadays, they may present with symptoms as fatigue and weakness. Uncommonly, older diabetics will present if they're not already known to be insulin dependent, and some type 2s are insulin dependent, it's uncommon to present with ketoacidosis. But it does occur. If they are insulin dependent diabetics, however, they will present with ketoacidosis. So acidosis. I would definitely have you anticipate that somebody, if they have an elevated blood sugar, blood glucose, would be possibly ketoacidotic. Now, don't forget that hyperosmotic, non-ketotic hyperglycemia does occur commonly in the older type 2 diabetic. And that's mostly a problem of dehydration. And of course, anyone who's hyperglycemic, if you think they're in ketosis, diabetic ketosis, or if they're not, or if you think they're simply just hyperglycemic, a non-ketotic coma, the treatment is fluids for you. And for me too. Upper GI bleed, gastrointestinal hemorrhages are common in the elderly. Peptic ulcer disease is the most common cause of upper GI bleed in older persons. Gastritis, esophageal varices, generally speaking, you have a history of alcoholism, you have other signs and symptoms of alcoholism, including ascites, signs of increased increased portal vein pressure. Mallory-Weiss tears occur from vomiting, and you can severe vomiting can tear the esophagus and the stomach, cause upper GI bleed. Now, upper GI bleed will be either frank blood, bright red blood, or blood that's been treated by stomach acid, which turns black in color because of the change in the hemoglobin, the iron in the hemoglobin with the acid, and you end up with either coffee ground emesis or black tarry stools. Melena, by definition, has to come through the stomach to get treated with acid. Could be the duodenum as well, but that's because there's a lot of acid still at that level. Now, lower GI blood bleeding, which is, if it's melena, that came from the upper GI. Lower GI bleeding is varying shades of blood. The most common cause in elderly adults is diverticular bleeding. The next is tumors, which is certainly a possibility. Usually it's a pretty significant tumor at that point. Ischemic colitis, which they've had a coronary attack of their GI system. So one of their major GI arteries have had an ischemic event, and you end up with a piece of dead bowel, which is causing bleeding then. AV malformations occur in the colon particularly, causing a lot of significant bleeding. How do you treat upper GI, lower GI bleeding? For you, it's treating blood pressure, etc. Fluids. So, black tar-like stool is melena, coffee ground emesis is upper GI bleeding. If they present with signs of orthostatic hypotension or frank hypotension or elevation of blood pressure or elevation of heart rate, then they need, and mental status changes, they need IV fluids. Remember that because we take a lot of, because they're on drugs, question them if they're on beta blockers, they're not going to have an elevated heart rate. So patient on beta blockers, hypotensive with a heart rate of 80, that doesn't make any sense, except that it's the beta blocker. They're in shock with inability to respond with increasing their heart rate. Bowel obstruction typically involves the small bowel, causes, usually they've had previous abdominal surgery, so they'll have scars or have had an intra-abdominal infection, peritonitis, and so they'll have scarring that will allow the bowel to strangulate on itself. They typically complain of diffuse abdominal pain, bloating, nausea, vomiting, fever, weakness. They may have shock, etc. Treated with IV fluids. Don't hesitate. If they have severe pain, it's okay to titrate small amounts of pain medication. You're not going to change the effect of the surgeon finding it. Itching may be caused by dermatitis, such as eczema or environmental conditions. People get dry skin and they itch. Particularly old people, we don't have as much oil in our skin, so It's easy to dry out and itching. More susceptible to bacterial infection of wounds, particularly if they have concomitant other diseases such as diabetes. Shingles occurs not infrequently in elderly persons, is decreasing in my experience now simply because we're pushing the shingle shot. Now if you go to the pharmacy and you're my age, they'll ask if you've had your shingle shot, because the pharmacists are giving out shots nowadays, and your flu shot, and your pneumonia shot, and all your other shots. You know, the pharmacist can deliver all that and cut the middleman out, the doctor. Shingles is never life-threatening, although it's extremely painful, but it can be eye-threatening, visual, particularly if it involves the upper part of the fifth nerve only, and gets around the eye, because you can actually get the varicella, the chicken pox, on the cornea, which can cause erosions of the cornea, ultimately lead to blindness. Pressure ulcers, decubitus ulcers, highest incidence occurs in nursing homes. This is, of course, why one of the reasons that the decubitus ulcer is one of the reasons that the trauma surgeons have such a thing about transporting, or why we have such a thing with the trauma surgeons about keeping people on long backboards, and making sure, because trauma surgeons want everybody transported on a long backboard if they've ever thought about having trauma. And old people on long backboards will develop decubitus ulcers in just a matter of several hours if you don't do something about it. Now, that's probably not going to happen in the Pacific Northwest, because we do not let people lay on their backboard for 4 to 5 to 8 hours before they're seen by the physician in the ER. But pressure ulcers occur over bony prominences in people who can't move, particularly bedridden patients. And we do all sorts of things in nursing homes and things to try to prevent it, and you still can't. So they use eggshell, what are called eggshell carton mattresses. They use air type flotation mattresses. They use all sorts of different things. And it's kind of a sign or symptom that they don't have adequate, they do or don't have adequate personnel in the nursing home to move patients regularly. They're difficult to treat once they develop, and it's better to prevent them than to try to treat them. They do treat, if you have access to a hyperbaric chamber, that can improve the treatments, but it's still difficult because you can't move. The fact that people aren't moving around is also the reason they can't get them into other treatment facilities. As we get older, many of us develop what are called inflammatory arthritis, ankylosing spondylitis, which gets primarily affects the spine, results in a stiff, inflexible spine, and that spine is extremely fragile, subject to fracture. The problem with a lot of people with ankylosing spondylitis is they also have quite a bit of kyphosis and or other spinal curvature, and they may have difficulty with breathing laying on their back. So transport from an injury, transport may be difficult. If you're going to If you need to do airway management, it's more, you don't have, the spine is too rigid to move. So you have to do, that's probably the place for your king airway. Transport and splinting may be difficult with their breathing. So here we have maybe the oldest trauma patient I've seen recently. 96-year-old male crashed his scooter. This is one of those self-propelled, I'm sitting in my scooter thing. He was found outside by his neighbors with his power chair on top of him, and he's crashed. He states he can't feel anything from his nipples down. States he has neck pain and back pain on palpation. When the patient's feet are touched, he has reflexes, but states he couldn't feel the pressure on his foot. So he's a 96-year-old, alert and oriented, confused, lethargic, IV access by fire, has no obvious trauma, but can't feel pain from the nipple line down, unable to move his legs when instructed. He's moved to a long backboard, placed in MICU, remains bradycardic, hypotensive. Second IV placed, 12 lead obtained, coarse lung sounds, so fluid challenge is stopped. Blood pressure continues to decline. He's given atropine with improvement in heart rate as well as blood pressure. See? And mental status. Now he's transported code 3 full trauma to Southwest. Initial blood pressure was 70/40, pulse of 38, sinus bradycardia. After getting his medication, blood pressure is 124, pulse is 45. I think it's going to come up some more. 127/50, 45. I think it did come up a little bit more in his heart rate. Now, except for his blood pressure being good, his pulse is okay, I think I wouldn't worry too much about that. If his blood pressure hadn't come up and his pulse was still in the 40-ish range, I think I would have been inclined to put an epi drip or a levofed drip on him. Now, gets to the ER and he has a past history of known ankylosing spondylitis, and he has fusion of his back spontaneously by ankylosing spondylosis for most of his thoracic spine and part of his cervical spine. And so what do you think happened? He had a rigid lower spine and a rigid upper spine, and he's got a fracture at C6, C7. And he does have hemiparalysis, or he doesn't have quadriparesis, he has paraparesis. He's not entirely knocked out. He has some reflex movement, he has some function himself, and he initially says, well, gee, I want to get this fixed. And the neurosurgeon then went through the whole process of discussing with him and his family as to what that meant to fixing this. And the chances are that he's not likely to survive the surgery in the first place. They were willing, but then he opted, he said, well, will I, if I don't do it, will I be in any pain? He said, are you in any pain at this moment? I said, no. He said, well, no. Then the answer is no. If you go to surgery, you're certainly going to have some pain if you survive the surgery. So he opted that he would have just custodial care, basically. Yeah. renal problems, renal failure, glomerulonephritis, renal blood clots, all common as we get older. Kidneys decrease in size, change in the walls of the renal artery due to atherosclerosis mostly. And so you get renal failure. Renal failure is heralded mostly for how we treat it with signs of hyperkalemia. Urinary tract infections are usually caused by bacteria, lead to urosepsis. Contributing factors, diabetes, inactivity, bed status, dementia, other neurologic things which keep you, flat in bed, or not moving much, and you don't drain your bladder adequately, or you have an indwelling catheter. That's 100% guaranteed to get some form of urinary tract infection. Sometimes it requires treatment, sometimes it's just chronic. Signs and symptoms, obviously we all know that wonderful sensation of walking into a patient's room and being able to tell it, yes, this is likely a urinary tract issue going on here. Urosepsis, which is a term that CMS, Medicare doesn't like anymore. They don't like you to call it urosepsis, but to me that just means sepsis caused by a urinary tract infection, which is heralded by, the same symptoms of any sepsis: fever, chills, but some abdominal discomfort, other signs of septic shock, including either hypotension or fever or low CO2 or rapid respiratory rate. Environmental emergencies in the elderly, hypothermia. Most hypothermia occurs in older adults, occurs not, and they're not out hiking in the woods, so it's occurring in their houses because they don't respond to changes in temperature as well. They don't shiver we don't shiver as well. We don't have the same muscular. The skin is thinner, more likely to lose heat. It occurs more commonly in persons with fixed incomes and so they don't keep their houses as warm, or they can't afford to keep their houses warm. They don't have adequate food. It occurs just accidentally. Usually non-specific complaints, slow speech, confusion, sleepiness. Elderly patients don't shiver, and treatment is the same, and prevention is the best treatment. Now, hyperthermia occurs because more commonly in the elderly, because our sweat glands have changed, age-related. They don't sweat as much. We have increased risk of heart disease, other concurrent things, diabetes, low changes in thyroid function, alcoholism, other drugs that we use, that we take, which has a tendency to increase your reaction to heat. Diagnosis is best made simply by taking their temperature. And we do lots of prevention strategies, but during this kind of heat-related thing, we have cooling things, and it's nice to have air conditioning, which makes a difference for but the elderly are more at risk for these things. Substance abuse is a big problem in the elderly, mostly related to things like depression from loss of employment, loss of feeling like you're worthwhile doing something, loss of spouse, multiple prescription drugs, malnutrition, loneliness, signs and symptoms of drug abuse, memory changes, drowsing, decreased vision, hearing, orthostatic hypotension, poor functioning, poor dexterity, mood changes, falling, restlessness, weight loss, a panoply of different things. Alcohol is so common, and it places anybody at risk of toxicity, but particularly the elderly who may be taking a lot of other medications too. Mood swings, denial that they're drinking too much, hostility, confusion, history of falls, people who are falling, particularly if their houses are not are adequate for them, or their living situation is adequate. Falling is generally a sign that something has major changed, and it's often alcohol. Lack of appetite, insomnia. Believe it or not, alcohol does not make you sleep better. Makes it worse. Anxiety, recurring episodes of nausea, often due to alcohol. Common psychological disorders related to age include organic brain syndromes that we've talked about, depression, very dependent personality, and paranoid disorders. They will become particularly dependent often on one or more members of their family, usually driving the daughter or son a little bit crazy because of their absolute dependency on that. They're often afraid of everything. My mother became a bit paranoid in her old age, and during one of the heat episodes in Portland, I went to visit her and found her house inside was about 102 degrees. Every window in the place was closed, and the air conditioning was off. And she wasn't looking that good at that point. And so we removed her from that situation, but she was totally convinced that the person down the street was spying on her. And so she was going to make sure that she couldn't get, that no one could, this was another woman, couldn't get into her house, and that she had all the drapes closed and all that. And I said, what about the air conditioner? She said, well, I didn't want it on because I didn't want her to know that someone was home. So she would have come very close to having a heat episode herself if we hadn't managed to get over there that particular day, because we had no idea that she was doing that. But they get very, very into imagined things often. Symptoms of depression in the elderly: sadness, despair. It may be negatively affected by their past psychological treatment or by experiences they've had. They may have current stressful events. They often are very hypochondriacal. They begin to obsess over little things that which had been chronically going on, and then it is the leading cause of suicide in the elderly. Now, the geriatric depression score, I'd like you guys to go through this and take it yourself, but if you get a score of greater than 5, you mean you're depressed, and you have like things like, are you basically satisfied with your life? Yes or no? Then down, do you often feel helpless? And then again, are you happy most of the time? Do you think it's wonderful to be alive now? We have one that's a Democratic questionnaire and a Republican questionnaire too. Trauma is the leading cause of death in the elderly. Contributing factors include osteoporosis, reduced cardiac reserve, decreased respiratory function, impaired renal function, decreased elasticity in the peripheral blood vessels. Blood pressure and pulse readings are deceptive, and patients' perception of pain is somewhat diminished. One of the best indicators of shock in the elderly is altered mental status. And remember the little old guy who rolled his scooter, he initially started out with a moderate mental status change, as well as he was hypotensive. But he responded pretty quickly then to the fluids and the atropine, and then he was at normal mental status from that point on throughout his hospital stay. Now this is a case brought to us from our St. Helens folks. 78-year-old male fell on Mount St. Helens. He walked 4 miles off the mountain with another climber, another person, and was transported from the climber's bivouac to Cougar. He reports neck pain after glissading down Mount St. Helens when he went off an 8-foot ledge onto a rock well, striking the back of his head on rocks and losing consciousness. Climbing partner who was behind him said he was unconscious for less than 30 seconds. After climbing from the snow well, patient's climbing partner noticed he was walking with an upper body list to the right side. He was aware of this and didn't know why it was occurring and was unable to correct it. The list was pronounced enough that each hiker they met on the trail said, "You're leaning kind of funny." Patient denies nausea, use of blood thinners, seizure history, reports his neck pain is manageable once secured to the long spinal board. Incidentally, he initially declined any medical attention. He initially said that no, he's fine, and he'd go to see his doctor if this persisted. They tied him down to the backboard. So they gave him full spinal precautions. He had full neurologic sensation. His pulse ox, blood pressure, heart rate, respiratory rate, everything is good. Blood glucose was good. Gave him a little fluid, not much. Transported him. Pain scale, he says 0, no pain. Got no pain at all. Just leaning funny. Everything remained stable. So he had no spinal injury. However, he had a left frontal hemorrhage and a subarachnoid hemorrhage and a small subdural hemorrhage, which responded simply to observation. He discharged home. He had outpatient neurology follow-up and outpatient some OT and physical therapy, and he now is standing up straight, apparently. He should give up mountain climbing, more than likely. Geriatric abuse and neglect, same as, to some extent, same as child abuse. Be suspicious for unexplained injury. This could happen possibly from this, in this particular presentation, could happen from somebody doing a face plant, although unlikely that it would have got across the bridge of the nose and not the nose if she went down like that. It's unlikely, just eye and cheek, and it looks almost, you can't say for sure, looking at it, that doesn't look like it looks like it may not be the same age injuries. It's not entirely explained, and pay attention to inconsistencies of report. Don't confront the family because they may be armed. Don't confront the family, that's not our point. Document, report, and we look it up. We'll check it out. Transport considerations in trauma: modify your position, immobilizing and packaging as needed. For trauma alerts, whether it's modified or full, we expect in most cases for the patient, if they're not on a long backboard, that they're on a gurney, they've got C-spine control, and they're flat on the gurney, except if there's a reason, a compelling reason, such as they can't breathe, flat. If you need to modify that's your decision. Now, one of the trauma and the elderly are not going to be complaining like this, but one of the trauma surgeons do not consider they do not consider negotiating with a patient for transport that would be something you can alter. That's not a reason for bringing somebody in a sitting up position. You have to have a reason for, you can't say, well, the patient didn't like it. If the patient can't breathe, that's a reason to have them sitting up. If the patient is just an argumentative butthead, we don't consider that an adequate reason. But if you can't transport them any other way, let the surgeon deal with the agitated butthead then. Trauma, remember, trauma places, an elderly person is more likely to become hypothermic than a younger person, or of course an infant. So treat extremes of age, protect against hypothermia in your transport with traumas. Orthopedic injuries, common injuries, and common causes of trauma, and used to be the most common cause of death in older persons was hip or pelvic fractures. They'd never walk again, they'd be bedridden, and they would get all the problems of being bedridden and get pneumonia and or get a pulmonary embolus or whatever. The hip or pelvic fracture is still the most likely things because of osteoporosis, and these are bones that have a long axis, so they are more likely to break. That's followed by the proximal humerus, distal radius, proximal tibia. Those are usually not life-threatening. Thoracic and lumbar bodies have spontaneous fractures often, and anytime they fall on their rear end, they're likely to compress vertebra. Elderly are at risk for, somewhat at risk for burns, particularly if they're if they're at home somewhat demented, taking care of themselves, easy to eat, and or if they smoke. If they get a burn, they're more at risk for shock because of they lose fluid and heat much quicker. They're already a little fluid short, so administration of fluids is important. For pre-hospital, you wouldn't do anything differently than you would normally do, which is to keep adequate fluids running during transport. Almost all elderly, we would decrease the percent and severity of burn and have them go to a burn center more easily than anyone else. They're going to need a burn center even if they have what you might consider, what I might consider a relatively minor burn in a younger adult. Complications are going generally occur from in the days and weeks following the incident. You're not likely to have a major complication at the time of your transport, but I think preferentially I would refer most elderly burns to a burn center. One of the issues, and this may have been a factor for this little guy with his head injury and two different kinds of internal bleeds, is that as we get older, the brain has a tendency to get somewhat smaller. You have a little bit more increased, you have a little more cerebral spinal fluid in there, and you end up with quite a space often between the brain and the skull. So you have room for a subdural hematoma without causing severe symptoms. It takes a lot of bleeding to get compression of the brain to cause that much increased intracranial pressure. Cervical spine is susceptible to injury due to osteoporosis and spondylosis. So that's why that little old guy with his scooter ended up with the fracture. Arthritic changes will compress nerve roots or spinal cord. It's called spinal stenosis. You get narrowing and sort of scarring of the where the nerve roots come out of the spinal cord, and they can cause compression. And then any trauma puts your spinal cord at greater risk then. Okay, we have a couple just minor changes on the protocols to refresh, and then we are done. Okay, I don't know if you're all aware of it. We have a sobering urgent response van called SERV. They call the one over in Portland Cheers. I guess we call this one SERV. The purpose is to safely transport patients to the sobering center. This can be called for by the police, or it can also be called for by EMS. Eligible individuals have to be 18 years or older, under the influence of drugs and or alcohol, or both, have a blood alcohol of 0.35 or less. How do you know that? Well, the SERV van can, the CNA on the SERV van will test for that. They have a breathalyzer. Law enforcement can test for that. The patient has to volunteer to go. They can't, if they want to go to the hospital, they end up going to the hospital. Individuals not eligible to go to are the ones who are not eligible to go to the sobering center. People who are complaining of other medical problems, chest, abdominal pain, shortness of breath, potential injuries, fractures, etc., lacerations, whatever that require ED evaluation, guys who have been beaten up. And if they have change in their vital signs. Heart rate 48 or less, or greater than 130, temperature greater than 102, less than 95, blood pressure greater than 180 systolic, or less than 90 systolic, so hypotensive or hypertensive, blood pressure greater than 120 diastolic, respirations greater than 30 or less than 10. These are the criteria that they use to turn them away at the sobering center. Unconscious patient does not go to the sobering center. Blood alcohol greater than 0.35. You have to ask, you have to have law enforcement or somebody do that. Blood glucose outside normal limits, if indicated. So, individuals not eligible for the sobering unit would go to the most appropriate ED for evaluation. You can get the sobering vehicle through Cresta dispatch or law enforcement personnel on the scene. Mark, what's the hours now? Okay. Till the bars close, right? Now, most of the time, this, at least in Vancouver, this is going to be called for by law enforcement. But fire can ask for it if the patient clears, meets the criteria. The most important thing is that it cannot be involuntary. The patient, and a lot of these guys have been there many times and they want to go back. It's a pure sobering facility.
Yes, stats of the
Yeah,
utilization.
well, Mark would know that more. I don't know. The utilization stats?
The capacity that they have, I believe, is roughly between 16 and 20 beds, depending on
Yeah.
time and how much staff they have there. Sobering van is staffed by one of the staff members and who is medically trained as either a CNA or advanced first aid, and then the other person is a mentor, so basically means they have gone through that themselves. Signed up for people, so there's two people on a van at all times.
Do we have to get a refusal? Fire for giving care to somebody that's lesser certificated? How's that work?
Well, it's within the state law now that we can transport to a an alternative facility. Would you get a refusal? Yeah, I would get a refusal. Make it simple.
Right now, they only respond part-time.
Based in Vancouver?
Yeah,
So,
Yeah,
plus
the
camp
sobering
CTA is
centers-
gonna be like half hour.
right.
Right. Sobering for you guys, yeah, you might take a while.
Yep.
Because when they're not responding to calls, they're out doing public outreach, and most of that is done in the city proper.
Right.
Their fee to use it? It's free.
And it's free to be in the center. It's all funded by grant.
And they give them resources before, or make them go through some sort of debriefing or resources before they're released?
They offer that. They
Yeah.
don't make them do anything, but they offer that.
This is entirely voluntary. They don't make anybody do anything. And many people have been there many times.
And the other thing, we work really close with law enforcement and the sobering center, so if there's, if the sobering van isn't available, then law enforcement knows that they can take and refer to the sobering center as well. So we have a bunch of if they want to go.
Okay. Another minor thing to your orders, hemorrhage control for arterial extremity hemorrhage, apply direct pressure bandage to the wound. If it is not effective or practical, apply commercially available tourniquet. Apply tourniquet as per manufacturer's recommendation. Note time and date on tourniquet label. Do not remove tourniquet prior to arrival at definitive care. Now, of course, that doesn't work in junctional injuries like in the groin. So it's going to take, that's where we use direct pressure and wound packing. And now, even though there are now coming out with, there are soon going to be some commercially available things for junctional hemorrhage tourniquet. Now, utilize improvised tourniquets only if commercially designed tourniquets unavailable. This is one, now, people say, can I, somebody put on a tourniquet when, they used a belt and twisted a little bit and and it's not a very good tourniquet. Can I take it off? And the answer is yes. Put your own on in place before you take it off. A lot of times you find out that there won't be any bleeding when you take it off. But if there is bleeding, then you have your own tourniquet there, which is an adequate, which is a correct tourniquet. Most of the time, the improvised tourniquets don't work like you thought they were going to do. They just get venous control only. Other protocol changes, septic shock, or any shock for that matter, document time and amount of fluid given. We're having problems with that. Furosemide, pulled it. Forget the Lasix. Remove from the formulary. So use nitrates and CPAP or PEEP for congestive failure pulmonary edema. We also removed it from the Hyper-K protocol just to be consistent that you don't have to use furosemide. It is a third-line drug in congestive failure and probably causes more trouble than it's worth. It does cause. Now, for phosphodiesterase inhibitor, i.e. Viagra, Levitra, et cetera, Cialis, two bathtubs. We have cleared up the language, so we say nitroglycerin administration is contraindicated. So don't use nitro on people with chest pain who've had a phosphodiesterase inhibitor in the last 48 hours. Hypoglycemia, slightly changed the definition because of current studies. It's hypoglycemia is 60 milligrams or less in a non-diabetic, but 80 milligrams or less in a known diabetic. Insulin dependent or not, known diabetic. So just keep that in mind. So that's kind of your endpoint too. If you've treated somebody who's a known diabetic, you treat them for hypoglycemia and you get a blood glucose after the fact and it's less than 80, better give them some more. Treatment for Benadryl overdose, I mentioned that earlier. We're making that the same as TCA overdose, is you administer sodium bicarbonate. These things all have effect on QT prolongation, wide QRSs, et cetera. So treat it the same as as a TCA overdose. It probably works for a lot of other overdoses too, but we don't have the proof of that yet. Okay, a couple of very straightforward, easy things, I guess. So, any questions, any issues, any thoughts? Next month is going to be respiratory, and Dr. Mox will be doing that one. I'll be here, but Dr. Mox will be doing it. Okay.
My infant stretched his little hands imploringly to me, while struggling in the vulture's grasp, all vainly to get free. I heard his agonizing cries, all loud and long he screamed, until amidst the azure sky